All right. Well, thanks everyone for coming. And Zach, your talk really was visionary, sort of to put everything together. I really enjoyed that a lot. I'll be talking about our initiative that we started now more than 2 years ago, and we want to move the field forward here. Does this work? No, it doesn't. Yep. So my disclosures. I do teaching for Joymax as well as EO Spine. Here are the objectives. I would like to, familiarize you with technology-based strategies for prospective outcome collection, understand the impact of prospective data, familiarize yourself with the ESRG quality improvement initiatives, and understand the vision of spine care moving forward. Here's a little bit of an overview. So before we start here right now, I think one thing that we always kind of forget about is I would like to express my sincere gratitude for the trust of our patients in us and in our surgical skills. After all, we are people with knives, and not everybody would be trusted. But in the end of the day, to the eye of the patient, this is who we are, right? So it's when we look at the data, and this is the data, I just pulled it earlier. This is the data from the ESRG prospective data collected, and what is plotted here is like how much improvement of pain and disability do we see within the first 3 months. And on the x-axis, you see how much improvement to the right. We have improvement of the disability. How much improvement of leg pain do we have? And you can see that 85% of more than 350 data points that we have there, 85% of patients are improved in our surgeries. However, 15% of our patients are the same or worse. And this is, I think, where we really have the obligation to further refine the indications and improve our procedures. And I think I would take this up to any other surgical technique. I mean, from a sample like this to get only 15% of patients that have no improvement or worse, and 85% of improved patients is amazing, and I think we see that every time, but I don't want to stop there. So this is what we did there. What we started a couple of years ago, a collaborative research effort, and again, a lot of the surgeons are in the room here right now. We meet on a monthly basis. We have exchange of ideas, aim to develop new strategies. And together we do things like here, where we put stuff together, look at our data, and advance the field. Here's a little bit of timeline. 2022 was the first meeting in June. We have now more than 1,000 patients in our database. We have written all these papers during this time, so we are highly productive. 7 peer-reviewed studies. We have 17 manuscripts in preparation currently. And a big thank you to Natalie, Catherine, B, and Amy, who is helping us with the IRB submissions. Without them, we could not have done all of this. So how do we get there? Within 2 years, 7 high-impact papers. So these are the issues that everybody here faces. The EMR, documentation madness, integrated outcome collection, and administrative roadblocks. 35% of our time that we work as physicians, we are documenting. We're collecting data and we're putting it down. There's a huge waste of resources and of our time. Introduction of the EMR has increased the time another 9%. So we are glorified secretaries. And so what we're trying to do now is like, how can we make this better and how can we integrate that? So in our outcome collection, so the members of this group, we are saving time that we can use for research to generate these things automatically and integrate that. We have decreased the time that we need for follow-up, so everything happens electronically now. We have standard questionnaires about well-being, and almost all patients in my practice choose virtual aftercare. Nobody wants to come to your clinic. Those 85% of patients, they don't want to see you, sorry. They want to live on with their life. The 15%, you'll hear about those guys, rightfully so. But the 85% are going to be in there. And without this technology option, you never hear about these 85%. So what are we doing right now? What did we do before? Well, everybody knows that, right? Like, chart reviews, right? Go back there, scroll through that. The issues, it's retrospective. There's patient selection bias. There's missing data. There's spine registries that are prospectively collected. However, it's very resource intense. You need nurses calling. You need a lot of personnel. You need and typically, anybody who's been involved in these registries, they're typically transient efforts. With other words, once you have like 500-600 patients, people are done with it. It's just like, because you need to put so much effort into that. And none of this makes my life easier. These are the emails I get typically at 11 p.m. after I come home from the OR. It's the delinquency emails, the stuff that I haven't closed and all this stuff. That makes me really happy before you go to bed. And then the pandemic came and everything got even more messed up. And so the issue was that we had telemedicine visits, so I had no idea how my patients were doing. Rapid turnover of personnel. So the person who was scanning in the PDFs was gone. And we couldn't get any more prompts. And so now everything is automated. The prompts, we have continuous monitoring, so we know how much the patients are stepping. And we can now circumvent those administrative roadblocks. I've, in my institution, tried to implement several multi-institutional studies and failed pretty much for all of them. It is just almost impossible to get multi-center trials up and running, given the protocol development, regulatory improvements, funding, contracts, site selection, training, data management plan, quality insurance, communication infrastructure. This is almost too much to do. So very difficult to do. And so instead of this, we now can collect, together using technology options. And we looked at the adaptation of patients. Almost all patients wanted to have virtual care, 91%. 85%, we had some idea how they were doing. And 3 months follow-up was available in 74%, and 100% were compliant with virtual follow-ups. So nobody wants to come back to you. So where does this get us? So we have a workflow, at least at the UW right now, that we have, we do this with technology, standardized surveys, patients are enrolled either conservative care, continuous physiological monitoring, or surgical intervention. And as Sak pointed out, we have a common language that we speak, and we have quite extensive surveys. We found that patients, if they're not engaged initially, those first 7 days, you lose them. It's kind of almost like, the goose and the mom when they need that time for bonding. The first 7 days after surgery is really when the patients kind of like, start engaging with you, and you need that time. And then the virtual follow-ups, which saves everybody time. And this is a great thing, is like when you take a registry or other research, you don't learn from this. And I learned from my great mentor and colleague, Dr. Chestnut, is nothing kills confidence like patient follow-up. All right? And if you do studies, you never get this, because by the time you have the data, it's years and years afterwards. But this is what we get now, is like, patient has leg pain on the contralateral side. Well, you know what? I used the wrong caris and I was beating up the contralateral nerve root, right? So, was more careful with the contralateral decompression. Here we go. Here's post-op of muscle cramps, so you can see how your intervention immediately affects the outcome. And this one I didn't understand. I called her and she had broken her femur. So, but you can actually get those data and you can learn real time. And I think that's something that we have lost because our throughput is so big. People used to be in hospitals. We saw our patients every day. We were interns and residents. We don't have that anymore with these surgeries. And the other thing is that is great is like we can actually go through a line of patients my last 8 patients, and you can really see what we do and the impact of endoscopic spine surgery that is either minor compared to a traditional surgery or moderate, where synovial cyst is a very minor impact on the difference from endoscopic to open technique, right? But if I go to a T2, T3 endoscopic discectomy, well, compared to open surgery, this would be a major, major impact in terms of invasiveness, lateral discs, And then obviously the ability to do revision surgeries within arthrodesis constructs. And so we see now that when we look at that in real time is how much impact our endoscopic practice has and how we can decrease the invasiveness. All these procedures will be much, much larger and much more invasive without this technology. And so what can we do on a multi-center field now, putting all the data together? Again, the data is collected at multiple centers. The data it's a gigantic data spreadsheet of millions of data points. And what we can do, for example, we can compare outcomes. So this is the preoperative pain VAS pain score, and this is 3 months afterwards. So we can actually see that our outcomes in the whole group is almost to the point the same. So it's very, very similar, very standardized. And the big frequent argument that I heard all the time is, well, Dr. Hofstetter, you can do it, nobody else can do it. Well, that's not true. So you can go to any ESRG surgeon and you'll have the same outcome, which is awesome. So we don't have to travel anymore so much. So a couple things here before we come to the end here right now. So what can we do with this data? A couple things. So we looked at early outcomes using this prospective data in 122 patients. And patients either had discectomies and had decompression surgeries. And we collected the PROMs. As you can see here, this is what it looks like. And this was really interesting because this has a true impact immediately on any conversation you have with a patient, right? So who would ever tell the patient before that if you have a discectomy on day 1, you have complete leg pain release? This is like, hundreds of patients here right now. And the interesting thing was then, but the disability took 90 days. In other words, the patient you call them the next day is like, do you have pain? No. But they still cannot, travel. They can't sit. They can't help me what the ODI entails, right? Walk, sit, travel. Social activities, exactly. Anybody else? Okay, perfect. So I know we're waiting for yeah. We'll take that tonight. I can't believe that. Anyhow, so all these things and this is important when you talk to your patient, right? You want to prepare them, right? The pain is gone tomorrow, but you will need time to rehab, and it will take time. And very similar to laminectomies too. In laminectomies, there's a little bit more of a curve, often a little bit of a 2-3 days afterwards, a little bit of a fluctuation in pain. But this is really useful to counsel your patients. And so 78% of discectomies and 70% of ULBD have MCID, a minimally clinically important difference at 3 months. So you can see that at 3 months, patients are doing fairly well. Another thing is really interesting. We're looking at age, for example. So we looked at patients younger than 50, older than 70. And you can see how the endoscopic procedures are tailored towards patients of different ages. So patients that were younger had mainly transfemoral discectomies, and the older patients had laminectomies. And so you can see that older patients had more levels done, longer operative time, and were less frequent outpatient. But the great thing is both patient groups had amazing outcomes. In terms of leg pain relief, very similar. ODI, in fact, they were the best. And back pain, we had too few patients there to really make a good statement there. But you can see that even for patients above 70, this type of surgery works well. 2 more studies that I wanted to highlight here right now. More than 1,000 patients that the ESRG looked at and compared them with 5,936 patients from the NESQIC database. And what we found in this study is that the surgical site infections was decreased by a factor of 16. So you're 16 times less likely to have a surgical site infection. And another study that we did very recently is looking at more than 1,000 patients of the ESRG against 92,000 patients from the NESQIC database. We looked at the 30-day readmission rate. That's a quality control that hospitals look at. Full endoscopic surgery is 1.1%, and traditional is 4.4% of a propensity matched sort of cohort. And so patients with endoscopic spine surgery are 4 times less likely to come back to the hospital. And again, this is a quality metrics that hospitals have to look at. And I think that brings me to the conclusion here right now, and I'm not going to sing, I promise you. My last fellow, God bless him, he was the biggest Taylor Swift fan, and so he got this T-shirt here right now, which took me a lot of effort to get this Taylor Swift line there. But so the vision is that we can decrease the burden on simple manual documentation and other tasks, and you can use this effort and energy more meaningful. We want to define benchmark outcomes, improve the quality, and implement AI solutions for documentations and communication. And this is all very much available. So with that, thank you so much for listening, and any questions I'm happy to answer.